Hi, good evening all. Can you hear me? Can you type somewhere that I'm audible and I'm visible, and Dr. Kelly is also there on your screen, and maybe her presentation is there on the screen, that is pediatric dental trauma and odontogenic infections. Yes, that's wonderful. We got a feedback from our attendees that we are audible, as well as the screen is there. Yes. So very good evening to all of you, and somewhere it may be good afternoon, and maybe somewhere it is good morning. So here we have a wonderful speaker today, Dr. Kelly Kirtland, and she has a lot of degrees to her credit. I was going through the CV which she has sent me through email. Right from Doctor of Dental Surgery, that is DDS, then General Practice Dental Residency, then Pediatric Dental Residency, and then she was a Master's in Clinical Course, then Master's in Human Nutrition, then Master's in Education Administration, and then she was a Master's in Business Administration. And apart from that, she is a pediatric dentist, she is an educator, she is a business operator, and she is a team leader. And she was a vice president of Ohio Academy of Pediatric Dentistry, and then she was a president of Eton Dental Society. And she is a fellow since 2001 of American Academy of Pediatric Dentistry, and she's on the speaker list of American Academy of Pediatric Dentistry since many years. And she's an oral board examiner of AAPD, American Board of Pediatric Dentistry. And she's also national board test conductor for American Dental Association and so many other things. And I won't take much of time, and I won't be in between you and our speaker, Dr. Kelly Kirtland. And I welcome Dr. Kelly, and I request you to start your webinar, and wish you all the best, and wish you all attendees good lecture. Thank you so much, and I'll see you after our webinar, but I'll be with you all the time, but I'll get back to you after we finish the webinar with the questions which you will be writing. I'll take one by one all the questions with Dr. Kelly, and we will try to answer all the questions, and preferably write one question each, because we have total today more than 400 attendees. Just within 2 minutes, we had more than 400 attendees on the list. So it becomes difficult to sometimes to answer all the questions. So I request all of you to put one question each. Maybe in one go, you can put your all questions, and so that I should be able to communicate with our Kelly to give the answers back to you. And thank you, all of you, for being here. And now over to Dr. Kelly.
Good morning, everyone, or good evening, depending on good afternoon, depending on where you're tuning in from. My name is Kelly Kirtland, and I'm a pediatric dentist. I'm very fortunate to be here. Thank you so much, Dr. Goyal, for the invitation. It is my pleasure to share my education and knowledge with everyone. Practice right out of dental school, and it was done within the Department of Oral Surgery at Denver Health Medical Center. We had a mandible fracture every night. It was truly the knife and gun club, we call it here. We took care of prisoners, gang members, trauma patients, very victims of domestic violence, very sad. And during that year, I learned so in college, and then I did a pediatric dental residency in Cleveland, taking care of children who were at high risk and craniofacial syndromes. Truly challenging work, and I'm so grateful to all my educators for all my wonderful experiences. Anyway, so I know a little bit about pediatric dental that they really harped on us for at the hospital. Dr. Goyal did a great job introducing me. I also teach Introduction to Pharmacology at the University of Cincinnati Blue Ash, and I teach the the expanded function dental auxiliary students there. I also teach at the Miami Valley Hospital at their general practice residency program. I teach them about pediatric dentistry, private practice management, and the hospital with me and observe me in the operating room. Moving forward, I don't have any disclosures. I'm not being paid. This is my pleasure to share with you. I don't know if you all are familiar, but if you go to giantmicrobes.com, you too can get a stuffed COVID-19 stuffed animal for your office. Resources are really important. Pediatric dentistry. I've administered oral boards, gosh, I want to say 8 times. We have a trauma form that's free. The American Academy of Pediatric Dentistry provides. I provided a link. Another excellent form to follow is from the dentaltraumaguide.org. I think now, though, you have to pay to be a member of the Dental Trauma Guide. The trauma form provides a systematic way to evaluate, and that's what the American Academy of Pediatric Dentistry is really trying to get us to do, to provide a systematic evaluation. Same thing every time so that you don't miss anything, such as loss of consciousness, are there tetanus vaccinations up to date, and then starting with the extraoral exam and moving to the intraoral exam. I thought I'd start with orofacial injuries. When I'm evaluating a child, we want to evaluate them extraorally, intraorally. There may be combination intraoral and extraoral lesions both. There could be soft tissue only lacerations. There are dental traumatic injuries, alveolar housing fractures, and other facial fractures, Lefort's and mandible fractures and whatnot. Let's start with extraoral injuries. Some children just fall and get what we call road rash, non-suturable injuries. There are also injuries that require suturing. And then you could have facial and dental injuries that involve more than just teeth or skin. Isn't she cute? Non-children are very top heavy. Their heads are very heavy. They're unsteady on their feet. They don't have great balance, and they don't have the reflexes that adults do. When you and I fall, we put a hand out and we break a wrist. When children fall, they just fall on their faces. And so road rash injuries, abrasions happen. And all you really need to do is clean them very gently with warm soap, disinfectant. If there are dirt or stones involved, you want to remove those to reduce your risk of infection. Rinse them, pat them dry, and then place some kind of ointment like petroleum jelly or triple antibiotic. I think all of us have had children who've fallen down and taken a tumble. Suturable facial lacerations depends on the depth and the length and the breadth of the injury. For operations like splitting open eyebrow or this little boy, you need a sterile suture kit and gloves. I particularly like to clean wounds with sterile saline or sterile water. I like saline because it kills bacteria and viruses. If you have a deep laceration, you can't just suture over the top. You want to suture the underlayers of the tissue, and I like to use Vicryl for that. Monofilament, something very fine with a tiny needle like a 5/0 or a 6/0 to minimize scarring. Very popular in the United States right now using Dermabond. Dermabond is just cyanoacrylate. It's just got a fancy medical name. And then you can place ointment or petroleum jelly over it. If you use a suture that needs to be removed, usually about a week will do it. One thing that we ask of our medical colleagues, please advise us if you have, if a child has concussion or a C-spine injury. I was called to see a patient at bedside, a young woman who had been in a car accident, and they were trying to rule out if she had a C-spine injury, and she was wearing a collar. She was in the ICU. She was sedated, and her mental status was poor. Anyway, I went in to see her and got scolded because I wanted to evaluate. She had a loose tooth, and they were concerned it was an aspiration risk. And which is the priority? Is it the C-spine or is it an aspiration risk? Is it something that can wait? We can always splint a tooth later on. So anyway, please advise us. It could also be an aspiration risk, and so that could be an issue when you have C-spine injury. Intraoral injury. Degloving is a frequent injury that I see at the hospital, the children's hospitals where I'm on staff. Tongue lacerations and mucosal lacerations. I think we've all seen this, a torn maxillary frenum. It's nothing to get excited about. Please know that it is uncommon in children 8 to 18 months because they're not very mobile. So if you see an injury in an infant who is not able to toddle or scoot, you might want to consider child abuse. In a child who's greater than, in a child who's under 8 months of age. In a child who's 8 to 18 months of age who is able to toddle or scoot, then we see those injuries quite frequently. But if it's under 8 months of age, we worry that they're being force-fed, something like that. So is the child ambulatory or non-ambulatory? Usually in these instances, there's no treatment required, just to reassure the mom. If they have pain, you can use children's ibuprofen or Tylenol. A popsicle always makes things feel better, and it should heal within 14 days, and he should be just fine. Gingival tears and degloving. I see this quite often. When a major tear happens like this, it clearly needs some suturing. And if the child isn't cooperative, we may need sedation. Generally, we can take them to the OR or an emergency room. They'll sedate the kids with ketamine. You want to make sure that you have a non-sterile suture tray and gloves. And of course, we get them numb, and then we irrigate the wound and to kill bacteria and viruses. And then I like to use suture with 3.0 or 4.0 chromic gut. I like to use interrupted sutures, so God forbid the child should end up with an infection, you can release one of the sutures or two of the sutures. You don't have to release them all. I like to suture between the teeth and below the contact point. On the facial side. So 3 and 4.0 chromic gut are resorbable, and they should just fall out. And sometimes after the tissue swelling goes down, the child will just reach in and pull them out and hand them to you. But if the suture remains, like if you ended up using silk or something, I like the knot to be on the facial side so you can access it easily. And I like to leave 1/4 inch long tails. This lecture was originally prepared for nurses and nurse practitioners and emergency room physicians who aren't as familiar as you all with the administration of local anesthesia. So we want to make sure that we anesthetize properly on the facial and on the lingual side, and we want to see that bubble of anesthetic. Intraoral suturing. I like chromic gut because in the mouth you want to tie knots tightly, not like on the skin where you have them lie flat. So knots should be tied tightly, and then eventually the swelling from the injury and the trauma will abate, and then the suture will become loose, and the resorbable sutures will just fall out on their own. Please suture the inner dental papilla, and please do not suture over a socket unless the child has a bleeding disorder. Suturing over a socket seals in bacteria and can create an abscess, and that's something we don't need. We want drainage. And we pass the needle under the contacts. Here's a couple of pictures I shamelessly stole from Google Images. Here's another great picture of intraoral suturing with the knots on the facial. You want to take a big enough bite of the inner dental papilla that it doesn't pull through. 1/4 inch tails, and that way you can get a hold of it when you go to remove them. Gingival trauma, you know, in young children, it's so hard to say, should you suture an injury like this or should you not? I bet you could ask 400 different dentists, should you suture this or should you not? And 200 will say yes and 200 will say no. Things can heal by secondary intention, and we're so fortunate. There's undifferentiated cells everywhere, just waiting for an injury to happen. Think about pizza or soup burns that happen and eating, I don't know, something rough like toast. There's always minor injuries to the mouth, and we're just unaware that these little cells run to that area and create buccal mucosa or palatal tissue or whatever it is that's needed, and it's repaired very quickly. Most injuries, if they're not too flappy, like the tissue isn't waving in the wind. In a 2 or 3 year old, if I saw this injury, I might just let them go. It's kind of a personal preference, and 2 and 3 year olds are very tough customers, and so if we were to suture that, we'd have to sedate the child, and then there's always the risk of, especially a special needs child, pulling the sutures out himself that you just placed. Tongue lacerations. Most of the time these heal by secondary intention and you don't have to do anything. However, with this picture, this one's pretty deep. There could be foreign body in there. So I think this child should go to the OR and under general anesthesia, clean that out, restore it, maybe even take an x-ray of it and make sure there isn't tooth letter C or H on him. So you want to make sure that that's just due to his age and not that a piece of tooth isn't in there. Again, you can give a lingual nerve block, especially if it's on one side. Please don't, well, if he were awake, you wouldn't want to inject directly into the tongue. I know our physician colleagues do that a lot. We can teach you how to give a lingual block, and it's much more comfortable. Again, I would use Vicryl for deep tissues, and then I would use 3 or 4 Chromica to close and leave 1/4 inch long tails. Tongue wounds hurt. Took off a growth on a young gentleman's tongue during my general practice residency, and he told me it was one of the most painful things he had ever endured. And he was a day laborer, and so he said every day, swallowing all day long. So these are very, very painful injuries and take a long time to heal. You can have combination intra and extraoral injuries. I couldn't find a really good picture of a through and through injury, but if you can use your imagination a little bit. Lip lacerations, I like to use intraoral anesthesia. If you give an injection in the vestibule, that's going to be a lot more comfortable than sticking a needle into her lip. When they're through and through, you need a sterile tray and a non-sterile tray. And what we try to do is, after anesthetizing, irrigate the wound with sterile saline, and then throw a suture over the vermilion border where the colored part of the lip meets the lighter tissue, just to make sure it's aligned properly. Can get it's crooked, and there's nothing that looks worse than the border being off. So throw one suture there that you'll later remove. And then use your non-sterile tray and suture the intraoral laceration to close the mucosa and seal off the oral cavity from the rest of it. After that's done, then you can re-irrigate, and this time you want to change your glove and your sterile suture for the lip. Vicryl for deep again, and then I like to use 5 or 6-0 monofilament for skin and have the tail stand straight up. Now our favorite part, dental injuries. Tooth concussion, enamel-only fractures, enamel and dentin fractures, enamel and dentin fractures into the pulp, open root apex, closed root apex, and root fractures. Let's talk about tooth concussion. Who doesn't see this in their office every day? And the mom calls and says, well, I think he fell last week or 2 weeks ago, and now all of a sudden you have a child with a dark tooth. This often happens while children are learning to walk. Again, they're top heavy and they tend to fall and bump teeth on the bathtub or the coffee table. The pulp in this tooth is probably non-vital, it's necrotic, but as long as there's no parulus, no visible appearance of abscess, the textbook says it, and hope that it doesn't create an infection. We always warn the mom that an infection could happen, and if it did, then something called a parulus, or if 2 were to appear, we call paruli. A parulus will appear and the teeth will be discolored. In this particular picture, I think not only is the upper left central incisor necrotic, and you can see they both look a little dark to me. So this child clearly has had it, and I think there are caries actually developing in between those two. So there's a dental abscess, it's draining. I get lots of questions from my nurse practitioner friends, do we need to give this child antibiotics? And the answer is no. Why not? Because it's actively draining in the mouth. The child does not have a facial swelling, and really he just needs good dentistry. The tooth is acting as the source of the infection, so you just really need to provide local anesthetic, remove the tooth, and once you've removed the source of the infection, Much like when you remove a splinter from your finger, once you've removed the source of the infection will resolve. And is this an emergency? Do you have to treat this right away? No, you have a few days, a week. You just don't want to let it go on forever. We don't want that pus to be bathing the permanent tooth bud, all that acid. We hope that it doesn't cause a change in morphology of the permanent tooth, the succedaneous tooth. Dental fractures. So these look like little enamel-only fractures. They're not that big of a deal. I don't think they require treatment. If you were to restore it, it's just going to come right off again anyway. The child will fall, or he'll bite on a toy, or children put everything in their mouths. I tell the moms if they're upset about their appearance, I can use a flat wheel diamond or with my high speed, or I can use a coarse disc and polish those and make them smooth and make them look great in their kindergarten picture. There are different classifications of fractures just in the enamel. Like this is class 1, class 2 is enamel and dentin, class 3 is enamel, dentin, and pulp, and that's what we really worry about. Class 4 is usually enamel, dentin. You know, if you just call me and say you chipped the enamel or it's in the dentin, but I don't see any pink, there's no pulp present, usually I can assess them that way, or you can send me a picture. When you have class 2 or 3 fractures, this child doesn't look too bad, and this tooth on the upper right central incisor. What concerns me more is the upper left central. You have a mirror to evaluate the lingual, because that fracture may be in the pulp and you're just unaware of it. And the question is, what should you do to treat these teeth? So I try to give parents a range of options. The first option, of course, is to do nothing. So you could just leave them alone, provided they're not in the pulp, and over time, the pulp will lay down tertiary dentin, scarred dentin, and wall itself off from the injury where it's near the pulp, like near this little mesial incisal corner. It's probably really close right there, and it's probably close on the lingual of that. Some parents are fine with it. Other parents don't want their children to look like a snake. They call it. Sometimes we'll take them to the operating room or sedate them, provide some mild sedation in the office, and see if we can put some crowns on there. Zirconia crowns have been really popular and pretty straightforward, and I've had really good results with those and enjoy using them. You could also use a strip crown. A composite crown, kind of. If I were to use a composite crown, I would roughen up the entire facial, roughen up the entire lingual, fit your strip crown, fill it with composite, and then you etch bond and put the strip crown on, cut the little shell off, and then polish them, because they always look too square, like chiclets, and they're always too thick on the lingual. So the emergence profile on the lingual is too thick with strip crowns. You always have to polish them down with a fine grit football. If you use zirconia crowns, you need to do a certain amount of tooth reduction and just cement them on, and they look great. If the fracture is into the pulp, then we like to do a pulpotomy as quickly as possible, preferably within the exposed to the oral bacteria, the more likely it is to become necrotic. Dental fractures. So a child could come in and have his teeth present, he could smile at you. You always want to put your fingers on the tooth and move them. A tooth is most likely to fracture where the enamel meets the cement in the root, and in which case you'll feel the tooth will feel very floppy, kind of like just relaxing your wrist and the benefit of an x-ray, I can almost always tell you it's fractured at the neck of the tooth. If you hold the tooth and the tooth moves bodily, like you move your arm, then probably he just did damage to the bone surrounding the tooth. He did damage to the socket. Conversely, if you just see no teeth, don't assume that they've all been knocked out, avulsed completely. You want to always make sure you take a radiograph and find out where the teeth are. If the root fragments are less than 2 millimeters long, then you can leave them and the body should resorb them and shouldn't be an issue. If the root fragments are longer than 2 millimeters, then you really should go in and remove them to reduce the risk of infection. Dental fractures of permanent teeth. This will wipe the smile off my face every day. So the question again is this fracture just in the enamel and the dentin, or do we have a pulp exposure? If you just see blushing of the dentin, it's just a little pink, then you can assume there's been a micro exposure, but you can place a glass ionomer liner or base, like Vitrabond is my personal favorite. Been using it since dental school and it still works really well. Vitrabond releases fluoride into the tooth. It seals that little pinpoint micro exposure. Eventually will lay down scar and wall itself away from the noxious stimulus. If there's an exposure of pulp, we'll get to that, I'll show you some pictures. Anyway, if you see a fracture like this, provided it's not in the pulp, the child does not need treatment that very day. He should follow up with his general dentist or pediatric dentist in the next 3 days, I think is very adequate. Please make sure you locate the piece of tooth that's missing. It could be in the child's lip, or in other soft tissue, and we want to make sure that we locate that. Here's Vitrabond, like I was talking about. It's very simple to use. Again, I made this presentation for nurses. Dry off the tooth and place cotton rolls. Paint Vitrabond on the blushing or the light pink dentin near the pulp exposure. Light cure it for 10 seconds. Please be careful when you use a curing light really close to pulp exposures. If you put the light directly on the tooth, you could fry the pulp. And make it non-vital. So I try to keep it close to a centimeter away and do it for 10 seconds, 2 beeps. I should address the suturing job. That was not one of mine. This is a stock photo. That suturing job is not very good. But the reason I selected this picture is because that is a big pulp exposure. And it depends on the age of the child. So first erupts in the mouth, the root is 1/2 to 2/3 formed. And you want to maintain pulpal vitality to allow for apexogenesis, to allow the end of the root to continue forming. So you want to keep that pulp vital if possible. If the child, so for example, in the central incisor, they erupt when the child's about 7 or so, and the root should be finished. The root should be completely formed. Apexogenesis should be complete around age 10. So if this child is 8 or 9, I'm going to assume, well, of course, I'll take a radiograph, but I'll assume that the root apex isn't fully formed and I need to do something. So what do? I remove amount of pulp and place MTA, mineral trioxide aggregate, which is completely non-reactive with the pulp. Any other medication you place directly on the pulp will cause pulpal necrosis over time, pulpal irritation. So MTA is really your best friend. So general or local anesthesia, remove a little bit of a small layer of the, so you get good hemostasis. I went to an endodontic lecturer who said they prefer to use a damp cotton pellet with pressure to get hemostasis. He says that anything other than that can create pulpal necrosis. Well, I've had traumas where I just could not get that bleeding to stop, and they say it takes 6 to 11 minutes with pressure with a damp cotton pellet to get hemostasis. Well, those of us who work on children know a child is not going to sit still for 11 minutes. So sometimes I will use pulp, I'll use cotton pellets that are racemic epinephrine pellets, but it can get into the systemic circulation and can cause a little bit of mild tachycardia. So be aware of that. Once you've placed this, you place a little MTA, and then I like to place Vitrabond to seal it in the tooth, and then you can restore your tooth. So here's a good diagram of a child who has open apex and thin dentinal walls. If the tooth was arrested in development at this point, its longevity, its prognosis and not as good as it would be otherwise. So that's why it's so crucial to maintain pulpal vitality. Closed teeth with closed apices, so your basic 10-year-old and up, he probably requires a root canal, something that I prefer our general dentist or endodontist friends do. But if I were to see this child on a Sunday night at midnight or something, certainly spec pulpotomy with MTA, get him comfortable, and then refer him for endodontic therapy shortly thereafter. So here's again radiographic evidence of a young child who had a pulp exposure after a trauma. Spec pulpotomy was done, and then you can see apexogenesis has occurred. So again, the goal is to maintain pulpal vitality with immature teeth so apexogenesis can continue. Here's a child who had a spec pulpotomy and then later on had a root canal. Now, would it be optimal if the root apex was a little more closed like the adjacent tooth? Sure. But if it's fairly closed, usually they can make an MTA backfill with gutta percha. Dental displacement injuries. So we have intrusion, subluxation, lateral luxation, missing teeth, and avulsion. So intrusion injuries with primary teeth, and typically there's nothing you can do. There's no need to treat it. They have minimal should re-erupt with time, usually in 6 to 12 months, although I have seen a couple of cases where the tooth actually became ankylosed. If that's the case, I will typically extract the tooth when its predecessors exfoliate. So for example, in this child, if his lower 2 primary central incisors exfoliated, that would be about the time when I would recommend extraction of the ankylosed tooth. Intruded teeth can injure the permanent successor, but it's very rare. Usually the root apex slides right up the front of it and will re-erupt back down. And children who do fall at just that right angle, sometimes you'll see a little circular defect in the enamel on the facial, but typically no. So here's a child, and you can see the eruptive process in 2 months, 3 months, and 6 to 12 months after injury, you should see the tooth in its normal position. Intrusion of permanent teeth, more or less kind of the same thing. It should re-erupt with time. If you have one that is not re-erupting with time, my recommendation is to send them to an orthodontist who can, with slow, gentle traction, pull that tooth down with orthodontic appliances. So, and then you get pictures like this. So has this child had intrusive injuries or extrusion injuries? It's kind of hard to tell. In her phone, that'll give us an idea. As long as the teeth are not in crossbite or in traumatic occlusion, you can really leave this child alone, and over time the teeth will re-erupt and he should be fine. Please again follow up with your pediatric dentist or your general dentist to have an x-ray taken just to rule out root fracture or other dental fractures. Subluxation. Concussion you get in your head, well, teeth can be concussed. So if you look at this picture on your left and the patient's right? Have these teeth been concussed? Well, we could document the history, and then over time we should follow with radiographic changes or with discoloration changes. Any tooth that looks discolored may have a necrotic pulp. It could have chronically degenerating pulp where it's dying slowly with time. You'll probably need endodontic therapy. Lateral luxation, moving the teeth forward or back typically. If you have a young child who has teeth that are just mildly displaced like these two in your picture on your left, over time, a blood clot will fill in, bone will fill in, and hopefully with lip pressure and tongue pressure, those teeth should move back close to where they used to be. In this injury on the right, this is hopeless. There is no saving any of those teeth. You can see the sockets, the gingiva has been denuded, the roots have been denuded, the socket's been obliterated, there is no saving that, and those 4 incisors are hopeless. please don't just focus on the one big injury. Please also look at the lower incisors. I see trauma down there too. With lateral luxation, the bone is cancellous in children, so it has lots of air cells, like a kitchen sponge when you cut it in half. And these air cells can become compressed, and so there will be a void where the root is sitting in the socket and the tooth will be mobile. But over time, over in the next few hours, a blood clot will form, it'll form scaffolding, and then osteocytes can come to the area and fill that in from the apex up. No required. We do not splint primary teeth. We do not splint primary teeth. Just soft diet and analgesics. With adults, well, with this other picture, we clearly saw the bony socket was obliterated. The periodontium is terribly traumatized, and just extractions are necessary for that. You may choose to use a bone file and smooth the bone, but in children, their bone is hard like our bone, and you could irrigate that and suture it to the best of your ability. Soft diet, and that looked like a very dirty injury, so I would recommend analgesics and antibiotics. This is one I worry about. Sometimes we get called for lateral luxation injuries and the child's in traumatic occlusion, and every time he bites, he's going to re-injure that tooth. Either needs to be repositioned with simple finger pressure and gauze, or just needs to be extracted. So depending on the mobility and how the child's responding. Some children who have non-nutritive sucking habits use a pacifier, use thumb. They can put their thumb in there and that will actually reposition the tooth for you. Lateral luxation. Just quickly enough before the formation of the blood clot at the root apex. Typically, we can re-intrude the tooth and we can put a splint on there for 2 weeks and the tooth will be just fine. If I see this injury, emergency room patients, they are sitting in the waiting room for 4, 5, 6 hours. Once that tooth has been extruded, I can't reposition it, then I send you to the orthodontist to have that orthodontically repositioned. Beware of the missing tooth. Is the tooth really missing? No, look at that x-ray. The tooth has been intruded and has had a lateral luxation injury. So that tooth, you could remove it and then you can place a suture, probably in the interdental papilla on either side, and that would probably be the best course of action. Now, if the mother was very upset, could you leave the tooth? Yes, you could, but then you run the risk of the tooth erupting palatally. Missing teeth are not always missing teeth. We see here this child actually inhaled the tooth. So make sure you know it's avulsed. If the mother saw it on the playground, if the child's having any kind of difficulty breathing, if there's any concern at all, please just get a chest x-ray. It's so simple, and just make sure that you know where that tooth is. Avulsed teeth, please be careful, handle them only by the crown. Your fingers have oils and acids on them, and we want to maintain the vitality of the periodontal ligament cells that are on the root of the tooth so that the tooth will reattach. You want to put it back in the socket is the best place for it as soon as possible. If you're not able to do it or you're afraid to do it, you know, parents are afraid to do it, nurses are afraid to do it, place it in saliva, just have place it in milk or saline. Please do not place the tooth in water. In our, and if you put tooth in water, water will rush into the cell to try to create homeostasis, and the cells will lyse, they'll rupture, and then you have less chance of the tooth reattaching. If worse comes to awful, you can have the parent put the tooth in her own mouth, the mother of the child, if she's worried the child will swallow it, in like in the buccal vestibule, and then when you get wherever it is you're going, you can reimplant it then. We reposition these teeth and place a composite arch wire splint, so little blobs of composite, and I personally like to use an 014 or 0016 9 tie, something very flexible, and then the child will need a root canal with the general dentist at some point in the near future. I try to have them follow up within the week because you've disconnected the blood supply. Avulsion of primary teeth. Do not call me for this injury. So if you look, this child is of an age where he's probably 5.5, 6. So he's lost his lower tooth. Parental incisors are present. And so up top, if the child fell or bumped his mouth on something, he just helped Mother Nature. The textbook says, you know, permanent teeth erupt on the bottom first, then it's successors up top, and bottom top, bottom top. So this is pretty typical. He just helped Mother Nature. If your child is calm enough, put the tooth back in the socket. Keep the periodontal ligament cells alive so they can reattach. Don't scrub the root of the tooth. If you need to clean it off, you want to do it very gently. Hold the tooth by the crown and then pick off the dirt or stones with a dental instrument, and then rinse it with sterile saline. The child will need splinting, preferably within an hour. Here's a great picture. Typically, these are dirty injuries. The tooth is on the ground at the playground. Antibiotics are a good idea. And of course, analgesics for pain, to have the child eat a soft diet. It's very important to keep the splint clean. The child may not want to brush in the area because it's been damaged. Please keep the splint clean, brush gently in little circles. Remove the splint in 2 weeks to prevent ankylosis, unless you have a root. If you're in the apical 1/3 or so and you're trying to get that root fracture to heal, then even though there's a risk of ankylosis, we leave them splinted for 4 weeks. And again, the child will need a root canal with his general dentist. This is about the cleanest and least bloody mouth I've seen after a trauma, but evidently this is what we do: little etch, little bond, arch wire and composite splint. To your office and remove it. These are the things we need for splinting supplies. So I made this list for the nurses in the emergency room. Alveolar housing fractures. If you have a mild segment, and this typically happens in older people who have less cancellous bone, the bone is cortical, it's hard, it's dead. If you have a small segment like this one where it's fractured, you can anesthetize and then use your thumb and some pressure, and just like when you put a dislocated shoulder back in its socket, you can actually press that segment forward, and just like you would with any other avulsion injury, you want to splint that. The question is, for how long? You can check radiographically, you can remove the splint in 2 weeks. Typically bone takes 4 to 6 weeks to heal, but then you run the risk of ankylosis. So just depends on how mobile the segment is. How far the teeth were displaced. I've removed mild ones in 2 weeks and had great success. It wasn't mobile at all. I've had ones that were displaced significantly, and those I've left on for 4 weeks and had really good results. If you have the whole anterior sextant or the whole side of the face, this has gone on, then you need to contact your oral surgeon, and you really should have arch. If a piece of the facial bone, the buccal bone, for example, has fractured off and it has no contact, it's lost its blood supply, then you might end up losing, I've seen this with severe trauma, you might end up losing that buccal plate, in which case definitely need follow-up with periodontist and oral surgeon. Facial, maxillary, or mandibular fractures. So typically with facial fractures now, they get a facial CT because it's quick, and then you can see bony and soft tissue changes. With maxillary fractures, you can get a facial series of films. One of the things that the patient knows, hold on to the anterior segment of the maxilla, and if it moves, you have a Lefort fracture. So I can tell even if there isn't a film available for me. With facial and maxillary fractures especially, you want to check, make sure, remember when the doctor takes his finger and does this, what is he checking for? He's making sure your cranial nerves 2 and 4 and 6 are intact. see, that's what the perla is for. Pupils equal, round, reactive to light, and accommodation. So that's when they flick the pen light in your eye and make sure that you have iris accommodation, pupil accommodation. And then you want to check EOMI, make sure your extraoral, that one of your eye muscles isn't entrapped in an orbital fracture. So you'll see one eye move the way it should, especially in a diagonal pattern, and the other eye will not. So mandibular fractures. So for maxillary fractures, you get a facial series of plain films, and for mandibular fractures, you want to get a mandibular series. For zygomatic arch fractures, you want to have a Waters view where the head is tipped up. Depression, you might also be able to see it just extraorally. And then you want to get a Townes view as an anterior posterior view. If you have significant trauma, MVA, that kind of thing, then you want to get a CT with contrast and 2mm cuts from the hyoid bone and superiorly. For facial and maxillary and mandibular fractures, of course, they need to be admitted for IV antibiotics, sometimes steroids and pain medication. You can make this gentleman comfortable. He has an open fracture to the oral cavity, so he gets admitted. If he had a closed fracture where you could not see it except on x-ray, and then be treated the next day. This gentleman, you could also do something called a lasso ligature, where you take a piece of orthodontic wire, and I would loop the orthodontic wire not around this tooth or around this tooth, because the socket is not intact. And if you squeeze that together like a twist tie, like you tie bread together, these teeth may come out. What I would do is I would loop it around that side of the canine, because the canine is solid, or on the side of this lateral, and you don't even need to use anesthetic. It's uncomfortable, but they feel better once you reposition those segments, and then they can close and they can at least sleep more comfortably until they see the oral surgeon in the morning for arch bars or ORIF. ORIF is open reduction internal fixation. When you write your orders, you want to make sure that you keep the patient NPO overnight, so if the oral surgeons treat them in the morning, they can go to the OR. So our little munchkins, our favorite group, 6 months to 5 years. I talked to the nurses and nurse practitioners a little bit about dental caries. 25% of American children get a cavity by the time they're 3, and 40 to 50. The statistic, it really has to do everything to do with diet, which is one of the reasons I got an MS in nutrition. Dental caries is 5 times more common than asthma, which is supposed to be the most common disease of childhood. I personally think that if this were a medical issue, that they would say that this is a pandemic and somebody would do something about it. I tried to give them a tooth chart for reference so that they could see when teeth are, what the names of the teeth are, and when they're supposed to be present when they exfoliate. Like I said, bottom top, bottom top. So usually, you know, 5.5 or 6 months, the lower central incisors are have those two exfoliate. I talked to them a little bit about nursing caries. When a child like this comes to the ED and they're in pain, it is an urgency, and I feel terrible for the child, but immediate treatment does not need to happen, you know, at 10 o'clock on a Sunday night. This child should have comprehensive care, preferably under general anesthesia in the operating room, or sedated in your office. Very appropriate. Typically, I like children's ibuprofen as opposed to Tylenol. Ibuprofen decreases inflammation, and that pulp, I imagine those pulp exposures, the child has irreversible pulpitis, and that's what's really causing the issue. If there is no swelling, then antibiotics are not indicated. Severe early childhood caries, they have dental pain. Is the pain coming from the pulp, or is the pulp necrotic? And now we have pain in the periodontium that's becoming infected. So pulpitis can be reversible or irreversible, and typically ibuprofen will solve that. If you think this is the calm before the storm, that the child is going to have a facial swelling, he's going to have a dental abscess, then I think it's prudent, especially in this time of COVID, to prescribe antibiotics. So when you have a dental abscess, typically with primary teeth, we don't try to go to heroic measures most of the time, and we do try to extract ending to storable. Fruit snacks, I think, are the #1 cause of dental caries, these gummy things that I see. And I would say second to that is only juice. I would say juice in my 1 to 3s and fruit snacks in my 2 or 3s and older, because the length of the time they spend in the mouth. You can treat children if the caries are into the pulp of the and place a steel crown or a zirconia crown, and the tooth should last the lifetime of the tooth. And in the second primary molar, it's typically till age 11 or 12. You want to be careful and watch for pulpal changes though. So this pulpal canal looks nice and wide and open. I'm worried, are these just denticles? Is this an accessory canal? And so your chances of success with this tooth may be a little bit less. But obviously this pediatric dentist had great success with it. Dentition. They have grown-up teeth and baby teeth, 6 to 12 years. Shark teeth is not an emergency. So I can't tell you how many times I have parents call about this. Typically the roots are in the primary teeth are resorbing, and the permanent teeth are just showing up lingually. As long as the child can wiggle on the baby tooth and can get it out himself with tongue pressure over time, those lower central permanent incisors will move forward. Our 6 to 12s are our most common age for dental trauma. They are riding scooters and bikes, and they're on roller skates and roller blades, ruck sticks and skateboards, and they are fearless. They haven't learned that they could fall and break something. So they're uncoordinated, and so they often have these central incisors with immature roots. Overjets and retrognathic mandibles. So if you have a child who's very much class 2, it's very common in people who look like me, in Northern European descent. Almost all of us are class 2 at some point. So those children are at high risk for dental trauma. Permanent dentition in 12 to 18-year-olds, I would say in my 12-year-olds because their second permanent molars are erupting and the gingiva is inflamed. So I like to use a little ibuprofen, and warm salt water is very effective for both the eruption of second permanent molars and of third molars. Warm salt water kills bacteria and viruses. It reduces, because it's a hypertonic solution compared to your own cells, it draws out edema, and believe it or not, so I have them do it after breakfast, after lunch, after dinner, and before bed, and within 2 days they're feeling a little better. So permanent dentition. Wisdom teeth, there's that nasty operculum, especially if the uppers erupt prior to the lowers, which can happen. Every time they bite down, they'll be chewing on that. If you have a laser, you use that operculum, sometimes that'll make them feel a little bit better. But warm salt water, ibuprofen, typically no need for, and then because it's sore, they don't brush back there. So typically you don't need antibiotics. If it's third molars, you want to refer to an oral surgeon. My oral surgeon friends are asking us to please refer the children prior to the mandibular canal. So they like to see the kids when they're about 15 or 16 years old, when the crown is formed and maybe the superior portion of the root is formed, so that they can evaluate them and see if removal is necessary. When you remove a tooth before the roots are very long, there's a smaller hole to heal. There's less likelihood of paresthesia because the roots are not as close to the mandibular canal. Just really goes a lot better for everybody. If you send a child when they're too young, 14 or under generally, the third molar bud is like a gelatinous mass, and it's actually more difficult to remove. So 15, 16 is our optimal target age. So I try to get the kid through braces, and then once the orthodontics are done, have a look at the post-ortho pen and see what their development is. Last but not least, very briefly, infections of odontogenic origin. So what causes infections of odontogenic origin? I would say number one, carious exposure of the pulp. Second to that can be let's say you're doing a stainless steel crown on a tooth that has large caries, but you didn't see a pulp exposure, but there was an assumed micro exposure. We've all had a stainless steel crown that we did go south on us. There's a history of trauma to the tooth, like the concussed tooth we saw earlier. Sometimes the pulp becomes non-vital or necrotic, and the infection can spread to potential facial spaces. I'll show you some pictures. What are other differential diagnoses? You could have parotitis, you could have mumps caused by the paramyxovirus, salivary gland infections, sialadenitis, salivary stones that block a duct, and then I put this on here not because you'll see it, but you'll recognize the child. Yes, meaning his epiglottis is very inflamed and swollen. It's having a problem breathing. The mother may mistakenly take the child to you as opposed to the pediatrician, and the child will be sitting forward with his head forward, his mouth open, and saliva will be running out of his mouth, and he'll be in significant distress. If you see that, the child needs to be in. So call EMS. It's a scary thing. Dental abscesses, we all know what causes a dental abscess. We just discussed them, but what are the potential spaces in the face? You have canine space, which is most commonly affected for upper teeth, buccal space, submandibular space, sublingual space, submental space, and the lateral pharyngeal space. Some people don't know where the lateral pharyngeal space is. If you look in the posterior palate, where the uvula hangs down, the soft tissue bands on either side of it, of the soft palate, that's the lateral pharyngeal space. This is what it looks like on an x-ray when you have a carious exposure, a young child who very clearly needs our help. The literature from the AAPD recommends that the child has IV antibiotics if he's in no acute respiratory distress for 1 to 2 days, and then after that swelling has gone down. Currently, the child may have just a cellulitis, a diffuse spread of the bacterial invasion in his face. It takes 2 to 3 days, sometimes longer, for a nice pool of pus to occur so that we can extract the offending tooth and do an intraoral incision and drainage. So that's our thing. Try to have the child admitted for a day or two with IV antibiotics, maybe steroids, pain medication, see if he, and then see treatment, particularly doing an intraoral IND on somebody who's awake is not fun, especially not for a young child like this. These swellings from the canine space can go into the orbit and can go into the brain. So very important to get that child admitted. This child is in extreme distress. She has Ludwig's angina. It's an odontogenic infection. She needs, can localize it. I just did one of these a couple months ago. I had the ear, nose, and throat doc in the room with me. The hospital where I was doesn't have an oral surgeon. I would have called an oral surgeon. In our hospital, the ear, nose, and throat docs are there. And he was there with me in case he needed to do an extra oral incision and drainage, which is beyond my pay grade. I couldn't, it was the child I treated was tooth number 19. He was about 10, and he had a huge abscess. I couldn't even get a good PA of the tooth in the operating room because his sublingual swelling was so huge. Fortunately, after I anesthetized, I removed the tooth, and we had excellent, excellent drainage from that. And then I also did an intraoral incision and drainage, just because back in the affected space, you can get the anaerobic bacteria will be exposed back to oxygen. You can release these gases that the bacteria create, and the child will heal. Initially, you may have slightly increased swelling because of surgical trauma. When you have a child with Ludwig's angina, how do you know? Well, in her case, the buccal space will be infected, and her masseter muscle may be so irritated and inflamed that she has trismus, and she can only open maybe 1 centimeter or 2, which is really scary. Sometimes after the children go to sleep under general anesthesia, their muscles will, we can actually them, and then they can intubate, and sometimes not. Sometimes children like this will need to be trached. They'll have infection into the buccal, submandibular, submental, and sometimes the lateral pharyngeal space. If they have an infection in the lateral pharyngeal space, you'll see the uvula is actually deviated. Anyway, this requires treatment in the operating room as soon as possible, and preferably with oral surgery or ENT. One other possible complication that children can have is a liver clot. A liver clot looks like a piece of liver. It's a disorganized clot. It oozes continuously. It has to be removed from the socket, and you with saline, or if the child's asleep and you're watching it in the operating room, you can recurette the socket to get a fresh organized clot. Just have the patient bite on gauze firmly for 15 minutes, and you can use a tea bag, has tannic acid if you're at home and you see this. 100 years from now, it will not matter what kind of car I drove, what kind of house I lived in, or how much money I had in the bank, but the world made a difference in the life of a child. And I want to thank you, all my pediatric colleagues, for doing everything that you do for children around the world every day. You're very special people. Questions and answers.
Yes, Dr. Kelly, thank you. We have few questions. One is from, because about, I think 10 questions are there. So quickly I'll take one by one. What is the etiology of degloving of gingiva? That is by Dr. Jackiran.
That's a great question. Little children will fall, and again, they're head heavy. They'll fall forward, and sometimes they'll just scrape the gingiva off, and they won't really even concuss the teeth. So I don't know why I see this injury so often in like 2-3 year olds, very young children. So they fall and they scrape their mouth on something, the back of the chair, a toy. They were holding a toy in their mouth and they fell, and the toy will scrape that up. So
okay, there is a question by Dr. Nisarga. That is what you said something about the sutures in special children. So can you repeat something about that, like sutures in special children?
Of course. Of course,
Yes.
in very young and special needs children, well, in all of us, whenever we have a suture in the mouth, it's something new and your tongue wants to play with it. It's a foreign body to them. Your mouth has so many nerve endings. It really is disturbing to children who do not like to be outside their norm and outside their routine. So it is not to care special needs child, like child with autism, for example, who has oral hypersensitivity, and I put him to sleep. I restored what teeth I could. I removed teeth. I placed a couple sutures for some reason or another. And when the child wakes up in the PACU, the sutures annoy him. He will reach in his mouth and just pull the sutures out and hand them to the parent or to the nurse. The best thing about the mouth is whether the sutures are there or not, it will heal. I just worry that if the gingiva are flappy, that they won't heal as quickly as they would as if they were in a fixed position.
Okay, there is a question by one of the postgraduate from Lucknow. She is Vishesh. She has mentioned that in case of deep tongue laceration, kid patient below 2 years is reporting after 2 days. He has not reported immediately after the injury. So is suturing still advised?
That's a great question. I was taught to, especially for lip injuries that are not going to heal, I was taught to cut fresh margins with a 15 blade and then suture and then irrigate and clean and then suture them at that time. With tongue lacerations, it depends on the and the depth. They will fill in by themselves. I worry about puncture wounds. You're not supposed to suture over those because you can seal in the bacteria. So if the wound is small, less than say 7 to 10 centimeters, maybe, or 7 to 10 millimeters, maybe, you can probably just have the patient irrigate it with sterile saline with a monoject syringe and keep it clean. And then over the next couple weeks, it should granulate in from the bottom up. If you had to cut fresh margins, I would only do that with the patient asleep, and I would do it in the operating room where you can control a bleed. That's a tough one. If the laceration after everything in 6 hours is usually a good ballpark guideline.
Okay. Like one more question by Dr. Umay Habiba. She has mentioned that if the tongue is lacerated deeply in the midline, and we need to give a block bilaterally to anesthetize the tongue, which is not recommended because there is always a chances of falling back of the tongue if we bilaterally block the lingual nerve. So in that case, how do we anesthetize whenever there is a cut in the deep and we need to anesthetize both the right and left portion of the tongue?
That's a great question. I would give a bilateral lingual block anyway because you need to have good anesthesia for your patient, and then warn the parent that the child should be sitting up so his airway is open for the next 2 hours until the local anesthetic has worn off. If the child is exhausted after his trauma and after you've sutured, at least prop pillows underneath him and have the parent remain with him so that the tongue doesn't fall posteriorly. But most children, as long as they're not under general or coming anesthesia, will maintain their airways even if they have a bilateral lingual block in place.
Okay. There was one more question that was that how the cellulitis is formed. I think I can answer because cellulitis is nothing. It is the infection of the cellular adipose tissues in the aponeurotic basically spaces. So whenever a odontogenic infection comes down to the adipose tissues of the aponeurotic tissues, and that causes cellulitis. And then can we use devitalizer paste in primary teeth? Is it justified? Devitalizing paste.
Can you use what kind of paste?
Actually, I tell you, Kelly, I think I will be answered in a better way to Dr. Milan, because in India, there was a trend of using devitalizing paste because that is a solution to local anesthesia. Instead of giving a local anesthesia, people sometimes prefer going ahead with devitalizing paste. And in primary teeth, this devitalizing paste, which is arsenic free, is sometimes used because that avoids giving LA, and the children are very scary of injections. So sometimes they use it, but the literature doesn't support use of any devitalizer paste in the primary tooth. Even one day I was searching the net very recently about the use of devitalizer paste in primary tooth, and I could not find any literature except for one study, which I think was done in Maharashtra in 2015 or 2016. According to that, people in private practice still use these devitalizing paste, especially for the permanent teeth. But yes, in primary teeth, no doubt not to that extent. So that is I think the answer for that. So literature doesn't, but yes, because of behavioral issues and some practitioners want to avoid giving injections, so they give this devitalizing paste to non-vital the pulp of the primary teeth to complete their pulpectomy. So, and let me make it clear here, I'm taking one question from each of the attendee because there are many questions by different multiple questions from one attendee. So sorry for that because I have requested in the start of presentation that we only one question per attendee I'll take up because it's a long list. We had 463 participants in total today. So it's not possible to go ahead with multiple questions from each one of you. But yes, our email is there. Our personal email is also there. So anytime if you want to discuss anything, anytime you're most welcome. Our phone number is also displayed. Anytime we can discuss any topic, that's not a problem. And then we have one question, rather, what are air cell? I will also answer this by Gurvinder. Air cell is nothing. It is the bony cavities in the skull, like the sinuses. That is called as air cell in different terminology. And then another is why should not we splint the primary teeth? Is there any issue in supplanting the primary teeth? What's your views about it?
Well, I think the AAPD's view, and I hope I don't misquote them, is it's very difficult to have a young child you have local anesthesia used and keep the bleeding under control. And I think it's just very difficult and awkward. And I think they did some comparative studies and they found that really there isn't a whole lot of difference between just letting Mother Nature handle things and having a pediatric dentist intervene. So we just don't splint primary teeth, and usually they do very, very well.
Okay, one more question by Dr. Dimitra Jones. What are the best splint for avulsion?
Thank you, Dr. Jones. She was my classmate in dental school. Dr. Jones is wonderful. I personally prefer 0.014 or 0.016 NiTi nickel titanium wires, and then any old composite you have laying around the office is just fine. Other people use monofilament like fishing line, so something super flexible. The point is you want to really use a flexible wire, because if you use a rigid wire like a stainless steel wire, it can create ankylosis and that kind of thing. So they just want you to use a flexible wire. All teeth have dynamic movement, and we just want to replicate that.
Yes, there was one study also, like we can use a fish nylon line, and along with that, the ortho light cure GC cement we can use for supplanting. That was also one of the study, and it is published in a very reputed journal of endodontology. And this was a very recent 2016, I think. They have used it very, very successfully with a very good outcome. So that is also very user friendly and with good prognosis. That is also good, something great. And then one more question. What is the alternative to reimplantation of permanent teeth? Success with the reimplantation is not great anyway. Anything you would like to add, Dr. Kelly? Like any alternative to implantation? I don't think there is any alternative to reimplantation. If it is indicated and if it is possible, then I think one should go ahead with reimplantation. Maybe the prognosis maybe for 4 years, 5 years, 6 years, but own tooth is always own tooth. So with the clear cut discussion with the parents and with the consent of the parents and with explanation to the parents, I think we can go ahead with the implantation of a permanent tooth, because otherwise alternatives are only replacements, and replacements are always not as good as your natural thing. So what anything you would like to add?
No, Dr. Goyal, I think you addressed that very, very appropriately. I did have auto transplantation of a tooth. I had a 13-year-old, and tooth number 30 was just, they really, I mean, you would have needed crown lengthening and all this other business and endo, and we opted to remove her lower right first primary molar, excuse me. So they auto-transplanted tooth number 32, her lower right wisdom tooth, third molar, and reimplanted it in that area, and that seemed to work out very well because the teeth were of similar morphology and she was very young and healthy. But when you try to auto-transplant from a posterior site to an anterior site, the tooth morphology is never the same. The tooth often needs to have endodontic therapy. It doesn't work real well, and that I've seen.
Kelly, I think few of the people want to look at your PPT, few of the PPT. So if you permit me, and if they ask me to send the PDF of your PPT, may I forward your PDF of your PPT to attendees, if you permit me? Because they want to.
By all means.
Yeah. So then,
by all means, I'll be happy to send it to you.
Yeah, so I will send then. So I request all attendees to email me or WhatsApp me your request for the PPT, and I will forward you the PPT by email. And then we have one question from Dr. Adhishri Singh, that when during trauma the entire crown is lost and only the root is left into the socket, what could be the treatment options?
Well, we're talking about a primary tooth or permanent tooth. If it's a primary tooth,
permanent.
For primary, remove the root. If it's a permanent tooth, there's a couple things you can do, and things that we would prefer to do, especially if it's a central or lateral incisor. once you remove a tooth, the bone resorbs, and it's really hard to get that bone back. So root banking is one suggestion, where you remove, or decoronation we call it, where you remove part of the root tooth and then suture over it and allow the body to heal around it. And the presence of the root of that tooth will allow the body to keep the bone present in that area. And hopefully the tooth will not become infected because it's been sealed in by all the tissues. If there's not an infective process in the tooth, like if the tooth didn't have caries into the pulp, and it's a young, healthy child, then this should be very successful. And you can maintain the root of that tooth for years, hopefully through the child's teenage years, until he's old enough to have an implant, and will still probably need to have a bone graft. But and talk to any periodontist trying to get bone vertical in the anterior, very difficult. So
Okay.
I suppose you could also do root canal on what's left and then maintain it that way, but usually you don't even have to do that.
Okay. Dr. Rupali has asked, what are the treatment options for open apex, non-vital, young permanent teeth apart from MTA?
Great question.
What do you?
If pulp is non-vital, if the pulp is non-vital, when I was very young, not now, we did apexification, where you instrumented this wide blunderbuss apex and removed all the necrotic tissue, and I would irrigate with local anesthetic or something sterile, and then I'd pack it full of calcium hydroxide and replace that every it really is miserable. I've done it. It doesn't work very well. What's more successful now is something called revascularization, and your endodontic colleagues are going to know more about that than I. So they instrument the tooth, and then they actually use their files and go beyond the root apex to stimulate the cells beyond the root and get some kind of apical closure. Then an MTA plug is placed and endodontic therapy is performed. So something I'm very aware of, but not a procedure that I've done. So I do have a few endodontic colleagues who have children who are willing to see kids to take care of this.
Yes, regenerative endodontics can be tried apart from biodentine and MTA as a apical plug. Like previously we used to use calcium hydroxide, but now it is not recommended because putting calcium hydroxide for a very long time into the root canal leads to dimensional changes. Rather, it decreases the strength of the dentine and makes the tooth brittle and prone to fractures. So that's the reason we only go ahead with apical plug. And yes, newer technologies like newer treatment options like regenerative endodontics can be tried in selective cases, not in all the cases. And Dr. Shambhat, he's a very senior periodontist from southern India. He has mentioned that coconut water as a media, transport media for avulsed permanent teeth. What are your views about it? Like, can we use coconut water as a storage media? I don't know if you have used in USA coconut water, but yes, we have a lot of coconut, especially in this part of the country where Dr. Shambhat is teaching. So I'm sure he must have done some study also on that. So he needs to know about your views.
That thought had never occurred to me. Coconut water, as far as I know, as long as there's not added sugars to it, is isotonic. And it's probably better than plain water. My concern would be, is it pasteurized and processed and there's minimal bacteria in it, or is it is it contaminated? And so you prefer to put it in a non-contaminated medium, but then the mouth is contaminated with billions of bacteria. So I don't see why you couldn't use it. I just personally have never heard of it.
Okay. Dr. Raviraj has put one question, but unfortunately that question is coming into parts, and those all questions are differently placed, and I'm not able to recollect, read what actually he mean to ask. So I'm sorry, Dr. Ravi, I won't be able to take up your question, because all the lines were not into one place, and there were in between many questions. So I could not read your question. That is a problem. And then in case of a lateral luxation in a young permanent tooth, if the patient visit after 6 days of trauma, what are the protocols? What could be the protocol?
That's a great question. After 6 days, there's really not a whole lot you can do other than to take radiographs and monitor, and eventually I think the biggest thing is you really want to try to make sure that that tooth isn't in dental crossbite and there's trauma going on repeatedly. If that's the case, then orthodontics as quickly as possible to open the bite, move that tooth forward, and get them into proper occlusion. If that orthodontic therapy is not possible for the family, I suppose you could remove the just so it's not being repeatedly traumatized. Extraction, I suppose, is always an option, but definitely not preferred.
Okay, now I think we are almost in the end. One question by Dr. Vinela. She has mentioned that the child has an avulsion late night and parents washed the tooth completely and kept in a dry cover next day. So what are the options in a dry state and the delayed treatment? What are the options?
In my opinion, if the tooth is dry, it's not going to be successful. And it's like putting the splinter back into your finger. It's just a source of infection. If the parents just rinsed it off with water and then stuck it right back in the socket, that would be great. If they kept it in milk overnight, I have replanted teeth, I want to say 4 hours later, container with milk. I had a little boy who had trauma, who went to one hospital, and then they had to drive several hours to a hospital where I was during residency, and I replanted them, and that happened about 6 months before I graduated. And to my knowledge, the teeth were still present. So I prefer to do that within an hour, but if it's beyond, if it's up, lungs, teeth are damp, wet, moist, maybe, but prognosis goes down for sure. And if they're dry, I wouldn't even replant it.
Yes, very right. If the tooth is brought into dry state and the delayed treatment is there, and then it depends upon how much the apex is open. If the tooth is mature, I think we can do root canal treatment out of the mouth, and then we can condition the root with citric acid, put the tooth into fluoride solution, and then wash it with doxycycline solution. And still we can try reimplantation after you scrap off all the dead and non-vital fibers of the periodontal ligament. But we need to inform parents that absolutely there is zero prognosis about that. And if they are still ready to go go ahead with the treatment, then it's perfectly fine, because ultimately that tooth is going to lose. But you never know, because sometimes we have seen even with the poorest prognosis there is a success, and we have seen even with but we expect, especially it happens in reimplantation, we expect a very good prognosis, and the patient comes within a year that the tooth is mobile. So you never know how the body react and accept those reimplanted teeth. But yes, in a dry state and a delayed treatment, the prognosis is always very, very poor. And I think we have taken up all the questions, because there were about 150 questions in total, and most of the questions I've taken mixing with each other. And yes, there is mention, Harshita, sir, your email ID to ask for. Okay, I am writing my email ID here. Harshita, for all of you, you can just take a shot of it. Maybe I have mentioned here, I have sent to all. I think you must have received my email ID, but still my phone number, if you have a pen, or I will send the recording. My phone number is +9198 554 666 98 554 That is my phone number, and my email ID is virindrg gmail.com. That is my email ID, and you can just send me a text or an email. I will forward you the details, right? And any other question? Dr. Manita has said something, but I'm not able to find out her question. Dr. Manita, I could not find your question. How about the kids with Lesch-Nyhan syndrome who keep traumatizing tongue? Because there are kids who keep traumatizing tongue. What about those kids? Anything you would like to say about those kids who keep on traumatizing that tongue?
My experience with Lesch-Nyhan children is very minimal. I've only seen one, and I've had a couple of colleagues who've had a couple. You could try like a full occlusal night guard kind of a thing, you know, taking it off, removing it, cleaning the teeth, putting it back on, see if that traumatizes them less, something that opens their bite. You know, so it's higher in the posterior, but then you run the risk of intruding the teeth. And really, I hate to say this, but the only solution I've ever seen is those anterior, and it's sad, and it breaks my heart to see them. Have you had different experiences, Dr. Goyal?
No, actually, I have seen only one patient till now, and that patient, because these patients particularly have a problem with the uric acid production, because they have a lot of uric acid production, and because of that there are neurological abnormalities, and mostly these patients have a very early renal failure. So this is a sad condition. We cannot do anything because the pathology is somewhere else, but indirectly the other things are affected, and sometimes you just see your kids suffering. That is the only thing. Sometimes it happens, but yes, the life is very difficult because there are problems with the joints, because a lot of, and with the renal system, and ultimately the patient die with kidney failure and neurological issues. These are the problems with such patients. Any other question? I don't think there is any question now. And for the information of all of you, we are trying to organize one master class tomorrow at 8 o'clock in the evening, Indian Standard Time. And that class we have kept specially for the postgraduates. And we have invited many teachers, many speakers, all together from India only. And around 8 will be there. And you can put your questions, and one by one I will take up all the questions with all those mentors. And till now, whatever seminars you have attended like this, there may be few questions which were left unanswered. So my request is, whenever we put questions, try to put questions, one questions per attendee, because then it is easy for our host to manage. Otherwise it becomes difficult to read all 200 and 250 questions. And truthfully speaking, we want that everything should be answered. Then only the purpose of this webinar is. But sometimes because of time schedule, and because we have other webinars also in the pipeline, and sometimes our speakers are bound to go for some other duties. Like I know Kelly has to leave for some very, very important work now, because it's early morning for her. And that is the reason she said, Virender, I will be available at 8:30. Because after that I have to go. So because of those reasons, sometimes we are not able to answer your all questions, and hope you excuse us for that. And Dr. Manita has again mentioned that she has also one case of this syndrome. I understand, Dr. Manita, you must have had this case, and maybe and we should pray that we should not get another case in our life, because it's very painful to see those kids suffering whenever such a case is there, and sometimes we feel helpless also, right? And Bhumika, you have mentioned that how to join tomorrow's program. Definitely we'll, let me first finalize everything, and we will advertise this program on all groups. And I have already given my number, that is 98554 66666. You just text your number on this number, and if we finalize it, I will definitely send all of you the link to join us in that master class. No PPT will be there, no presentation will be there, only our interaction will be there. So I will be putting your questions to all the panelists, and they will definitely answer your questions. So with that, I thank you once again to Kelly for being with us, although you did not have much of time, and I know it was difficult for you to spare this time, and you could not find much of time to prepare. You also, I know, because what all was happening at the back end. So, but still you could make it. I'm really thankful to you, and I'm thankful to all the attendees for being with us. And see you hopefully tomorrow. Let me just finalize. I'll ask Dr. Gyanendra also. So we will finalize today, and then we will inform you all. And thank you so much. Take care of you well, and good night. And Kelly, good day. Thank you so much.
Thank you.
Thanks a lot.
Thank you for the opportunity, Dr. Goyal. Everybody have a great evening.
Yeah, thank you so much. Bye-bye. Thank you.